Good morning, everyone, and thank you for this opportunity. So we're going to be talking about an overview of chronic pelvic pain syndromes. Chronic pelvic pain is a symptom that can represent pathology in a specific organ system, a chronic pelvic pain syndrome, or both. Patients with chronic pelvic pain may have more than one etiology, and the evaluation should include identifying all treatable causes and distinguishing other possible etiologies. Chronic pelvic pain is defined as non-cyclic pain that persists for at least 6 months. The pain can be constant or episodic, but does not include cyclic pain that is otherwise associated with menses. A syndrome is defined as a complex of concurrent symptoms and signs that is collectively indicative of a disease, condition, dysfunction, or disorder. Nociceptive pain arises from damage to non-neural tissues and is due to activation of the nociceptors. Somatic pain arises from bone, joints, muscles, skin, or connective tissue, and is normally achy or throbbing in nature and is also known to be well localized. Visceral pain comes from visceral organs and may be poorly localized and intermittent. Inflammatory pain can be related to either an acute or chronic infection. Neuropathic pain may result after a lesion to the nerves. Centrally generated pain may be related to sympathetic nervous system and can result in chronic regional pain syndrome. Hypersensitivity is related to increased nerve activity and may result from increased activity from a standardized stimulus. Chronic pelvic pain can be a multifactorial condition, and therefore management requires a thorough evaluation of all pelvic pain organ domains, including the lower urinary tract, the male and genital female systems, the gastrointestinal domain, musculoskeletal, and an overlying neuropathic and psychologic and sexual aspects domains. Other comorbidities should also be evaluated as well. It usually requires a multidisciplinary approach to the evaluation and treatment. Of note, throughout this talk, we'll be talking about symptoms and signs. Symptoms are subjective indicators as perceived by the patient, while signs are observed by the physician. Lower urinary tract causes of chronic pelvic pain include the bladder and urethra and may include interstitial cystitis, painful bladder syndrome, renal stones, bladder foreign bodies, and urethral diverticuli. Presenting symptoms may include bladder or urethral pain, discomfort with filling or voiding, urinary urgency, frequency, incontinence, hesitancy, or pressure. Signs during the physical examination can include suprapubic or urethral tenderness, as well as tenderness of the pelvic floor muscles. The evaluation should include questionnaires to assess the pain, including O'Leary Sant and visual analog scales, voiding diaries, along with urinalysis and urine cultures as indicated. Cystoscopy can be used to identify any pathology in the urethra and bladder, but is not required in the diagnosis of bladder pain syndrome. An intravesical anesthetic challenge is useful in identifying pain generators versus referred pain. Urodynamics may be useful when there are concomitant disorders such as incontinence and voiding dysfunction. Further imaging, including ultrasound, MRI, and CAT scans, may be utilized if warranted. Women with complaints of chronic pelvic pain have a large differential which must be evaluated. Some of the common causes of chronic pelvic pain include vulvodynia, endometriosis, adenomyosis, pelvic inflammatory disease, adnexal pathology, adhesions, leiomyoma, malignancy, and dyspareunia. Less common causes include pelvic congestion syndrome and ovarian remnant syndrome. Symptoms can include sharp, dull, burning, aching, stabbing, voiding, and defecatory pain, or dyspareunia. These can be either diffuse or localized and associated with tenderness and exam with possible erythema. The evaluation includes a detailed history and physical examination, including questionnaires, a pelvic exam, Q-tip test, and trigger points to identify the pain generators. Further imaging may be warranted but is not necessary. Within the gastrointestinal domain, processes that can cause chronic pelvic pain include anorectal and colorectal etiology. These can include chronic proctalgia, which is defined as chronic or recurring pain that lasts at least 20 minutes, in contrast to proctalgia fugax, which is recurrent or episodic pain that lasts seconds to minutes, and the levator ani syndrome. Treatable causes such as anal fissures, abscesses, hemorrhoids, and anorectal Crohn's disease should also be evaluated. Colorectal causes include irritable bowel syndrome, inflammatory bowel disease, celiac disease, chronic constipation, and cancers. According to the Rome 4 criteria, IBS is now defined as recurrent abdominal pain that lasts at least 1 day per week in the last 3 months. The term discomfort has now been removed from the definition. Similar to the other domains, a complete evaluation is necessary, including identifying specific pain generators and on examination to identify the anorectal and colorectal causes. It also likely involves a referral to a gastroenterologist for further evaluation, who may perform a colonoscopy, ultrasound, CAT scan, or MRI as necessary. Musculoskeletal domain pain may originate from the muscles, fascia, ligaments, joints, or bones. Common complaints include abdominal pelvic pain that may be associated with sitting, movement, change in posture, or with sexual activity, or with bowel and voiding evacuation. This involves the pelvic floor muscles, the coccyx, the sacrococcygeal joint, and bony pain along the ramus, the ilium, and the ischium. Patients with myofascial pain may present with pain in the pelvis, vulva, bladder, rectum, or even referred areas such as the thighs, the hips, the buttocks, and the lower abdomen. Physical exam findings evaluate the muscle tone, tension, and spasms, which may include tender pelvic floor muscles, hypertonicity, and trigger points, which are hyperirritable, palpable nodules or taut bands that are painful on compression. Additionally, pain could be also along the joints or the bony pelvis. Further evaluation with trigger point injections can help identify the pain generators and also treat the muscles. These patients likely benefit from evaluation and treatment by specialized physical therapists and physiatrists. Within the neuropathic pain domain, patients may report burning, throbbing, stabbing, tingling, or paresthesias. Symptoms may be related to the sympathetic, centrally generated pain or somatic pain, which with a specific nerve injury, such as pudendal neuropathy. Examination should assess for tenderness, trigger points, and referred pain within the associated nerve distributions. Chronic regional pain syndrome is characterized by pain in a body region, often accompanied by sensory, motor, autonomic, and tropic signs, which can emerge after trauma or another inciting event. It is not in a specific nerve territory or domain, and it shows variable progression over time. Type 1 corresponds to patients without evidence of a specific peripheral nerve injury, while type 1 patients do have a specific nerve injury. The pathogenesis is poorly understood, but it is associated with proposed mechanisms that include inflammation and changes in pain perception at the level of the central nervous system. Somatic neuropathic pain is associated with a specific nerve injury following either compression, stretching, trauma, or surgery. For example, pudendal neuralgia can present with a disabling form of lancinating burning pain, and it is important to note that these patients will most likely report that the pain is improved by standing or in the supine position. Other nerves that are implicated are the ilioinguinal, iliohypogastric, genitofemoral, and obturator nerves. Presenting symptoms are associated with the muscles and the associated dermatomes. Neuroma formation can also cause continuous pain in that nerve distribution. Pain following mesh injury may also present with pain or bleeding during intercourse or complaints of the patient feeling the mesh. The mesh can cause local tenderness on exam and may also have mesh extrusion. Evaluation of the neurologic domain should aim to identify the specific triggers using cotton swab testing and pain mapping. Imaging such as an MRI may identify potential causes such as a Tarlov cyst on the sacral nerve roots. While certain questionnaires are available, they are not yet validated for chronic pelvic pain. As everyone knows, mental health can play a large role in chronic pelvic pain, and confounders such as depression, anxiety, somatization, substance misuse, and abuse should be evaluated. Worry, fear, and anxiety can have negative influences on pain. Depression and anxiety have been associated with the pain syndromes. Patients with chronic pelvic pain have been reported to have an increased pain catastrophizing thinking and increased anxiety. Some patients may also correlate stressful experiences such as abuse with their chronic pelvic pain. A thorough history, questionnaires, and formal psychological assessment should be a part of the evaluation. Patients with chronic pelvic pain syndromes have a higher prevalence of one or more of the comorbid syndromes and diseases than the general population. These include fibromyalgia, chronic fatigue syndromes, and systemic autoimmune diseases. A general medical evaluation, as well as additional laboratory testing and imaging, may be necessary to complete the evaluation.